Let's now move on to the area of neoadjuvant therapy. Clearly, there has been a lot of data now coming out from using immunotherapy in that setting with different checkpoint inhibitors. Hope, do you want to comment on the data that was presented here at San Antonio in the context of the existing data?
Yeah, it's really actually fascinating because now we're in another quandary. But the biggest trial is KEYNOTE-522, and that trial is really important because it shows our change in thinking. We want to do trials in the neoadjuvant setting, evaluating new drugs that are powered for event-free survival. So it has almost 1,200 patients. So that's really a new generation. It should be our standard. So the PCR endpoint was the first endpoint for that trial that added pembrolizumab to paclitaxel and carbo followed by AC. And everybody got paclitaxel carbo because you couldn't have a non-carbo arm. It would have been too big a trial. Take forever. So the interesting thing is they could get to that endpoint at 600 patients, and they saw more than a 13% improvement in PCR in those 600 patients. That is, I think, clinically very important to all of us. One of the highest PCR rates ever reported in a triple-negative population and a big population. They looked at the CPS score with that 22C3 antibody for PD-L1, no difference. Really nothing predicted any difference. The only thing that they showed at this meeting was that if you got weekly carbo, it was better than every 3-week carbo, which doesn't make a whole lot of sense.
I thought if your CPS score was higher, that you had like a 71% PCR
the
rate. The
PCR rates were higher, but the differential was about the same.
Okay.
So
there may be a prognostic.
The absolute number was higher.
And you know, the trouble is when you look at the CPS 20, it's like this many patients. So we're in a difficult situation of knowing, but there has been a suggestion that it's prognostic from a metastatic trial also. So that they'll be able to look at that more with event-free survival. But we're waiting for EFS. Toxicity was pretty modest, exactly what you would expect. And the EFS, which looks really encouraging with a tiny bit of events, we're waiting for. But then here we saw the Michelangelo Neo-TRIP trial where they gave atezolizumab with just a taxane and then went to surgery and taxane carbo and went to surgery. And basically the issue is, we think, maybe not giving an anthracycline before surgery because the PCR rates were actually not better with adding atezolizumab, which was kind of surprising given this big difference in the KEYNOTE-522 trial. But again, I have the bias that it's not agent specific, but that it is more that you actually generate a lot of immunity from the host by giving an anthracycline with cyclophosphamide. Maybe you don't need the cyclophosphamide, who knows?
So you're the expert in this by far, but can I just, one thing that occurred to me when we were seeing those data was, is it possible that part of the difference between the two trials was the duration? You know, I mean,
that people brought that up in the discussion also.
Duration of what?
Duration was longer.
Therapy.
But when we gave Pembro,
4 cycle versus 6 or whatever versus 8.
8
months versus
8 first.
Well, just in other words,
no, I see your point.
Did in the Italian study, did they have enough time to generate?
But you know what's
system to
interesting
generate the
is that
response?
maybe that is why in the I-SPY trial, we only gave 4 doses of Pembro, but everybody got AC afterwards, but it's only 2 months.
Actually,
So
no,
So
one
the
told us
answer
6
to
months.
that
And they
would be
had it on both
B59,
6 months.
which is
So-
B59, which is
Just 6 months on
atezo.
both.
No, so in I-SPY, what I'm just mentioning is that there were only 4 doses of Pembro. So it does bring up the question of whether or not it's really has anything to do with duration. And then lastly, the SAFFIR-2, which is fascinating, trial in France, looked at durvalumab versus continuing maintenance chemo. And as we've seen, if you take an unselected group of patients, getting maintenance chemo versus nothing, it results in a better outcome. And that we know that. That's a lot of trials. Turns out durvalumab wasn't much in this situation. It was an unselected group of patients, and maybe you need to give it in a different way or select the right group of patients. Like if you took the responders to checkpoint inhibition, maybe it would have made a difference. But so that trial needs some follow-up, but I think it's a little bit hard to interpret.
Or you need the immunotherapy has to have
Has to
chemotherapy.
get a
with it.
partner
Yeah.
first.
The triple negative population and the PD-L1 positive population.
There was a suggestion of benefit.
Yeah, it was
Yeah.
it was significant for survival. One was significant, one was not, but a small number, but very encouraging for the triple negative and for the PD-L1 positive, I thought.
So aren't the impassioned like 030 or whatever that is? Isn't that a longer design? You know, the other impassioned studies, the impassioned neoadjuvant studies with Tezo.
All of the
B59's a longer
all
design.
of the neoadjuvant to adjuvant trials now are continuing, except for some of the HER2, are continuing the immunotherapy for
But I'm more
like
asking. But what I'm
trastuzumab.
more asking is the amount of immunotherapy you get and chemo you get before surgery.
They're all giving everything up front.
Yeah.
Right, but it's like, instead of being, in the Michelangelo's, we said was
trip-like.
4
No, it was 6
cycles,
months.
this is like
It was
8 cycles now.
It was 8 cycles,
Right.
and each cycle was 3 weeks. So it was 6. It was 6 months. It was just two agents, but it was 6 months of.
I think
preoperative
that this area is going to be really complicated by the fact that we've got a lot of trials and the events are going to be small. They're not really, with the exception of some of the really large studies, powered to look at event-free survival. Here's where I think maybe some of our newer diagnostics with minimal residual burden might be informative. We're hoping that that area might allow us to shrink our trials, but clearly immunotherapy is has many different possible applications with many different agents. And the good news is that we have a lot of trials in this space. There's been a lot of interest from the community in subscribing patients to these trials.